Yakima Valley Community College Radiologic Sciences Program presents Radiographic Positioning. Sternum.
Let's talk about sternums today for our lesson. I have the patient up at the vertical board. I have 10 by 12 film going into the bucky tray, ID to the top, and I'm using an arm marker because I'm going to do a right anterior oblique, and I've moved it in a ways because I'm going to have some collimation. I'm choosing to do a right anterior oblique over left anterior oblique because I want to utilize the heart shadow to gain uniform density. The heart shadow will be in the way either LAO or an RAO, and you have to do an oblique because the sternum won't show up, or, well, it will show up, but it'll be underneath the spine in a true PA position. So your options are very slight LAO or very slight RAO, and the RAO is preferred because the heart will cover more of the sternum and therefore the density will be more uniform throughout the sternum. The degree of obliquity is probably 15 to 20 degrees. The more round the patient is, the less you need to oblique them. The more oval the patient is, narrow and long, the more you need to oblique the patient. But a trick that you can use is you put your fingers on the manubrial notch of the sternum and you feel for the spinous process, and you're evaluating the relationship of your hands. If she's steep, notice how my hands go further apart. If she's shallow, notice how my hands will become more aligned, and I barely want that sternum to clear the spine, so I want a shallow oblique, and I'm just looking at the patient here and separating the sternum from the spine. Okay? I'm going to find her manubrial notch here, and I'm looking at the white line of the board. I want the manubrial notch to be just to the right, just to that side of the center of the board, because the sternum in this position, it actually goes manubrial notch and angles left down to the xiphoid. So I'm going to start with the manubrial notch being slightly to that side of the center of the film, because the xiphoid will then end up being slightly towards this side of the center mark. So that's how I've decided how to position the patient side to side. You can also use the spinous process on a patient's back. See, here's the spinous process. And you're approximately 2 to 3 inches off of the spine. Again, the amount of being off of the spine will be determined by the degree of obliquity. But between knowing you're about 2 inches off of the spine there and seeing the placement of the manubrial notch being a little bit on that side of the center, you're happy with the centering. The height-wise of the board, I'm going to use the manubrial notch. This is what I'm trying to do here. Find the manubrial notch and then evaluate the film's edge to be 2 inches above the manubrial notch. If it is appropriate for you to palpate, if gender, female on female, and you can tell the patient isn't too modest, you can start by finding the angle of the rib. Don't start palpating for the sternum at the level of the breast, but you can actually feel the angle of the ribs. Let the patient know what you're doing and find the xiphoid process. If you can find the xiphoid process and the manubrial notch, you want to center the sternum to the film. So I'm happy with the film's edge being 2 inches above the manubrial notch. I found the xiphoid, and I'm very satisfied with the centering of the board, and then I fix my tube to match my film and readjust the collimation to approximately 8 by 12 inches. Collimation is very important with the sternum because the sternum is hard to see. Contrast is very low. You need to do anything that you can to make that sternum stand out, to be more obvious. Tight collimation will reduce the amount of scatter, which will in turn increase the amount of contrast. Also, keep your kilovolts down into the low 70 range. That will help the sternum to stand out with more contrast. The last thing we want to do is bring the arm up. We didn't change the position of the patient, but we're actually bringing the scapula out to the side, because if the arm is down, the scapula could actually be resting over the sternum. So we bring the arm out to the side. That pulls the scapula out of the way. When we look at an X-ray image, we want to see the sternum just to the side of the spine. It'll actually be to the left side of the spine. The sternum should be centered, and the sternum should be cleared of the scapular blade. We want the sternum centered, so I use the film's edge 2 inches above, or I palpated for the xiphoid process, the manubrial notch, and centered the sternum that way. Breathing instructions for the patient is, if possible, try to go for a breathing technique. Lower your MA station. That will increase your time, and have the patient continue the breathing process. And that will blur the posterior ribs. And this would be an RAO sternum. Kristen, do you have any suggestions for the lesson? Okay. We're going to change films and position for a lateral. Same 10 by 12. ID to the top. I'm actually going to do a right lateral in this setup because my patient can face me and I can see the centering. If you were in a room with different orientation, a left lateral would be more than adequate. But I like to see the sternum and I like to work from the front side of the patient, so I'm electing to do a right lateral. Again, you leave a 12 length and tight collimation side to side. With the patient in a erect position, she will stand feet separated out apart, and her arms will be behind her, and can you roll your shoulders back? That will help the sternum to stand out. Make sure the patient is in a true lateral position. Check the scapular blades and the pelvis region. Baby step forward, please. And why did I have her take a baby step forward? Let's have the camera focus on the board here again. And this is the center of your film. And here's her, I'm trying to work backwards without choking you. Here's her manubrial notch right here. And see how I'm evaluating it, and I want it to be a little bit back of the center of the film because the xiphoid process will be to the front. If you were centered like this, you can tell that the xiphoid is going to be projected outside of the field of view. Or if you're too far back, here's the center of your film and you have nothing up here. So use your hints here. Xiphoid process, slightly behind the center of the film. Patient's in a true lateral position. And with female, you must ignore the breast tissue. The sternum is actually at the base of the breast tissue here. She's in a gown, no jewelry, no bra. The sternum will be right at the base of the breast tissue. If breast tissue is being clipped outside of the collimated field, that's okay. Breast tissue is not a part of the exam. And on Kristen, her sternum doesn't jut out too far, so I'm actually going to collimate in tighter. And then I'd move that marker in just a little bit more. Elevate the patient's chin. And you would have the patient take in a deep breath and hold it in. And that would put more air in the lungs. The lungs will therefore show up a little bit more dense. Making the lung darker against the white bone will help enhance the contrast, will increase the contrast, and perhaps the sternum will show up a little bit better with a deep inspiration and low KVP for a grit, which is at the low 70s. If you've done a good job of positioning, the sternum will be projected away from the ribs. You will include its entire length, centered to the film with tight collimation. And if you're not in a lateral position, let me kind of mock here what will happen. The ribs come into the sternum here. And if you don't have them in a true lateral position, the body shifts, and the ribs will actually tend to come and cover up the ribs. And I actually, layman's language, I call these nubbins. If you see nubbins or bumps on that sternum, the patient was not in a true lateral position. You want the sternum in front of the ribs. Okay? And that completes a sternum exam. In wrapping up the discussion for a sternum, some techs, very few techs, will elect to alter the SID a little bit. Let's think about this. For an RAO sternum, you have the sternum close to the film, but you have posterior ribs over the sternum, possibly obscuring it. So some techs want to blur those ribs out. We mentioned a breathing technique, and I promoted the use of a breathing technique. It's not always possible to get high enough mass to get a good breathing technique, but again, whenever possible, lower that MA station 10, 20, 50 level. Then you can get a longer exposure time. But some techs will actually bring the SID in from a standard 40 to a 36 or maybe even a 30. We don't actually promote that because the skin dose of the patient will increase, but it does very definitely have a good effect on magnifying the posterior ribs, and in magnifying anything, you will blur those images out. So that's why some techs do choose to change the SID to a shorter SID. Now, if you think of the rationale behind that, would that be good rationale for a lateral? Patient's in a lateral position, and the sternum is already naturally at an increased OID. You would not want to bring the SID in from the standard 40 because you already have OID, which is taking away of the resolution of the sternum, making that, you're complicating your effort. So maintain your 40 inches for a lateral, no options there. And that concludes the lesson on the sternum.